As we're going to do chapter 12, the best way to follow me with chapter 12 is a combination of things. One, use page 108 and 109 in your textbook, kind of as your point of reference. This chapter is probably the only real kind of anatomy physiology chapter other than chapter 9 when we did vital signs. So what I've tried to do is really simplify taking each of the systems in our body, identifying the name of the system, identifying what are the major organs in that system, and then trying to identify 2 or 3 events that will likely happen with that system in the long-term care patient. So if you're going in a facility, what could I expect to see with somebody with a nervous disorder, a cardiovascular disorder, a pulmonary disorder, a urinary disorder, and so forth. So I've given you a handout, and that way you don't have to try to draw my ugly picture. What we'll do is we'll take each of these systems listed in here. Again, I'll identify with you roughly the major organs and then a couple things that could go wrong so that you kind of have an idea. Again, it's very basic. Just keep in mind that this is not intended to get really in-depth physiologically. So we'll give you a little extra for your money, but we'll go through this. So I'm going to first start with the nervous system. And in the nervous system, we are dealing with the brain, the spinal cord, and all the peripheral nerves. So when we think about what can happen to our long-term care residents in the nervous system, one of the things we think about is a cerebral vascular accident, which is also known as a stroke. Yep, CVA, okay? So it's not uncommon for our elderly population to have strokes. Now, there are a couple kinds of strokes that we see. One of the strokes we see is an occlusive type of stroke, where there's actually a clot that forms in one of those arteries that's taken blood and oxygen to the brain. Once that clot lodges, you have to think that everything beyond that is not getting blood. If it's not getting blood, it's not getting oxygen because it's piggybacked. And so that part of the brain is what is injured or damaged. That's why you see some people with strokes that can't speak, some people with strokes that have right-sided weakness, some people with strokes with left-sided weakness, because it depends on what part of the brain was affected. You can also have a hemorrhagic stroke. That's when the pressure just blows one of those arteries in the brain, opens it up, and the brain is bathed with blood that's not in a container. So the same thing, now that blood is not getting to a portion of the brain that it's supposed to, and because it doesn't get there, that part of brain tissue dies and there's permanent dysfunction. Our brain is super, super sensitive to being hypoxic or not getting the oxygen. So you have about an hour to an hour and a half window of time, if the stroke is clot, to get him to the hospital, give him a drug that will bust that up, perfuse the blood to that part of the brain, and restore function. But how often are you going to know that grandma's had a stroke in the last 30 minutes or hour? You don't typically. Maybe you talked to her on the phone the night before, or you had breakfast with her and you gone to check in the afternoon and she slumped in the recliner chair and her face is drooping and her arm is weak. You go, oh gosh, it looks like she's had a stroke. Well, when did she have it? Did she have it 30 minutes ago or did she have it 4 hours ago? If we knew she had it 30 minutes ago, there's this incredible protocol that they go through and they get them to the hospital and they get them to CT scan to make sure it's not hemorrhagic, because if I give them a clot-busting, blood-thinning agent, I'm going to really mess things up if it was hemorrhagic. Hoping that it is a clot, give the drug, restore perfusion, and hopefully save function. But it's really hard to find that window, and that's why we see so much with that. The second thing we may see in this category is forms of dementia or the Alzheimer's disease. And again, we don't have all the information we'd like to have about that, but we sure are seeing lots of folks with it. And again, it varies. There are people that have Alzheimer's or dementive disorders that are more pleasantly confused. There are some that are more aggressively confused. There are some that are so affected they don't know that if you put food in their mouth, they're supposed to chew and swallow. So first time I ever heard about a patient being on hospice with Alzheimer's disease, again, it was new to me teaching long-term care. It's like, gosh, why would you be on hospice for Alzheimer's? And it was a lady who was so affected that you could put something in her mouth and it would just sit there. Like you couldn't get her even to understand, swallow that, chew that, so they end up becoming terminal as a result of that. So dementia or Alzheimer's. The third thing in this category is not frequent, but I just want to make a note of it because for whatever reason, they've chosen to ask this several times on the state exam, and that's what to do with seizure disorders. Again, not that common in long-term care or our geriatric population, but in the past they have asked a question about what the CNA's role is in a patient having a seizure. And just because there's been so much for so many years about what you do you cram a spoon in their mouth so they don't swallow their tongue? Do you put a tongue depressor in there? Do you, try to open their jaw? Do you try to close their jaw? There's lots of misinformation that's been out there for years. And the answer that you guys need to know as a CNA, you are to move things away from around the residence to avoid injury during the seizure. It's going to potentially take medication and really aggressive management to stop it. So your answer is very basic. Move objects away from the resident in order to protect them from further harm during the seizure. If you want in your textbook to just highlight that as a reminder, page 116 of this chapter has a big yellow box, and it says that, okay? I will tell you, back when I was in training, it was taught to put like a metal spoon in their mouth. And they would say, you'd hear that, well, we don't want them to swallow their tongue. Well, first of all, you can't swallow your tongue. Your tongue is attached to your mandible. You can't swallow it, right? But what we really should have been trying to explain is we were trying for them to not bite their tongue, potentially bite off a piece of their tongue, and that they could swallow. Or again, with the blood, they could not hemorrhage out, but they could bleed and choke on their blood. So the idea, again, years ago, was if I get an object in their mouth and they can't clench their teeth down, it's a safer scenario. Well, we were wrong. And we were cramming objects in the mouth, and we were then lacerating the soft palate in the mouth, causing more bleeding, and so that became totally unrecognized. So just move objects away. All right, so that's the nervous system.
Is that right?
Yeah, it is. It's pouring. It is pouring. The next system we're going to go to is cardiovascular. And I'm going to this one because a cerebral vascular accident is to the brain as a myocardial infarction is to the heart. So a heart attack or myocardial infarction is to the heart, what a stroke is to the brain. So the same phenomena can happen. I can get a clot that gets lodged in one of these coronary vessels. There's a big vessel called the circumflex, there's an anterior descending, there's a posterior descending. When we talked with cardiac the other day, I showed you that picture of the heart. So you get a clot in one of those vessels, blood and oxygen does not get to that portion of the heart muscle gets damaged and dies, now my pump is ineffective. So again, depending on where that occlusion is, depends on what part of the heart is damaged. Now, it's been quite fascinating over the years is they have also developed a clot-busting drug for this scenario. So if we can get them in the hospital, we can determine that they're having a myocardial infarction, we can give them this clot-busting drug, we can get that clot dissolved and out of there, restore perfusion to that part of the heart, save tissue. And we also know that the heart is not as sensitive to the loss of blood and oxygen as the brain is. So we have a much larger window to aggressively manage that. Some of the literature says 12 hours, some of the literature even says 24 hours, which I wouldn't want to push it to that, but there is some literature that indicates that. So now it's really a good idea to get my patients into a clinical setting if they have chest pain, because I can manage that. The second thing is they can also have a hemorrhagic, but the second more common is an occlusive from like plaque buildup. So you get this gunk building up on the coronary arteries. You may have heard a family member say, oh, I had a catheterization and they told me I was 80% occluded, and you heard this number. What they were talking about is they found a vessel that was partially occluded. If it gets to the point that it's the lucky day that it occludes everything, that junk comes together, then I'm going to have the same idea. Nothing can get past that. But that's not blood. So I can't give a clot-busting drug to get in there and to dissolve that out. So now I need that patient to go to cardiac catheterization. I need the cardiologist to thread the rotor-rooter up in there and get in there and rotoblade this out, get that gunk out, probably put a stent or something in to keep the walls of that artery open and restore perfusion. So things again have changed from getting them quickly to the cath lab Because then if I get in there and it's not this and it's clot, I can just go ahead and inject the clot busting drug too. So there's lots of things that can be beneficial. So it's why you don't have somebody in the nursing home who, oh, they can't take care of themselves anymore because they had a myocardial infarction. We do really well with restoring people to some normal function. And if by chance they damaged a section of heart muscle, usually there's enough muscle that keeps it functional, but they then may have issues with congestive heart failure, CHF. So now the heart muscle just doesn't have the ability to respond normally. Was that a damage from a heart attack? Was that over years of high blood pressure? What was the reason? But the heart muscle doesn't work. I think I gave you guys the analogy back, maybe it was when we were doing vital signs, of the rubber band. You know, the same idea. If I give you one of the ponytail things and it's new, it's nice and tight, after you've used it for a couple months, it's all stretched out. Well, the heart has some similar capabilities to lose its elasticity and ability to function. So the second thing you might see is congestive heart failure. And then another term you may hear, and we don't use it as much, but angina or angina. And that's kind of a warning potentially to a stroke. So this may be the individual that has some of these coronary vessels partially occluded. Ooh. And so the flow is still getting to the heart, but if you ask that heart to work harder, you go out and mow the grass, you exert yourself, and those arteries just go screaming because it's trying now to pump more blood as your heart rate's going up, and you get chest pain. You get a little nervous. You go, oh, let me stop mowing the grass, let me sit down for just a minute. And you sit down and you rest, the pain goes away, and you think, oh, phew, that's okay. It's really not okay. It's great that our body knew to do that and give us a warning, but what happened is when we exerted more force on the heart, it didn't tolerate it, but when I stopped and let it resume to more normalcy, I could get that pain to go away. So it's called angina or angina. You might have had a grandparent that had a little brown bottle of nitroglycerin pills, and we would teach these patients to, if they had that pain that would resolve pretty easily, you could try a couple nitroglycerin pills before you came to the hospital. But those are the potential things we'll see there. All right, let's move over to the respiratory system or pulmonary system. And let me backtrack just a minute. I came over here and started with the diseases. The circulatory or cardiovascular is your heart, your arteries, your veins, arterioles, venules, capillaries. Okay, I forgot to mention the structures here. Okay, respiratory or pulmonary. Now I have the mouth and nose, the trachea, the windpipe, a right and left branch off the trachea, and the lungs. That's my pulmonary or respiratory. One of the things I may see in this category commonly is COPD. Remember from Jeopardy, that was chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. Chronic, long-lasting, obstructive airflow, pulmonary, the lungs, disease, a condition. Lots of commercials on TV now for, is your family member experiencing COPD? They've got all these new medicines to try to keep people to be able to have a reasonable quality of life, but many times these patients do end up on home oxygen or oxygen in the facility. Another thing that I may have in this category is pneumonia. Again, whether we're following flu season, which is what I would have lectured on last year at this time, versus COVID season, we are now dealing with the idea that these residents get pneumonia, and it's the pneumonia that inflames the lung tissue, prevents normal oxygenation, shortness of breath, and ultimately death. So it's why our residents, because of their immune system, they're compromised, we've got to protect them. If they have flu, we're doing everything we can to not get pneumonia. With COVID, we're hoping they don't get a pneumonia. Because again, it's treatable, but in our elderly, their immune system's compromised, their organs are not as healthy as ours, and they may not recover from that. There's also a term you may see called aspiration pneumonia. Aspiration pneumonia. I think I had that word on your vocabulary matching. That means your resident maybe was trying to chew or swallow or get something to drink. They inhaled with something in their mouth, and a foreign body went into their trachea, into their lungs. So they aspirated. Foreign matter gets into the lungs. Well, the lung's not designed to have foreign matter in it. And so what ends up happening again, inflammatory process, oxygenation problems, and complications, potentially ultimately death. Depending on what gets aspirated is the problem. If we have people that aspirate vomit, think about how much acid vomit has from the stomach. So the acidity of aspirating vomit is very corrosive to the lungs, versus aspirating, some water when they were getting something to drink. Still a problem in our elderly population. The other thing just to think about is, and I won't really put it up as a fourth one, but they don't have as much tidal volume as we do. If I gave you one of those cute little spirometer things after surgery and I had you do a couple really good deep breaths, well, you could blow that thing up, with some really good tidal volume. The residents just don't have that. The ability to have a high tidal volume is low. All right, let's go to the muscular skeletal system. This cute little structure right here is supposed to be the humerus. It's the bone, but muscular skeletal is bone, muscle, tendon, ligament. So anything that's part of that skeletal system. So in this category, we see contractures. Contractures are a tightening, shortening of those structures, so your patient ends up getting their elbows contracted, their knees contracted, they end up in that fetal position. Basically, if you don't use it, you lose it is a true phenomenon. You guys will have on Wednesday, you'll have it on the video tomorrow, range of motion exercises. And range of motion exercises are designed to prevent contractures. I feel like severe contractures in most instances is a form of neglect. If you're having somebody that you don't help them passively do range of motion, passively meaning they can't do it, like you've got to do it. If they're active, then they do it. Maybe they're assistive and I can help them, but if they're to the point that they can't do it, we have to do it to prevent contractures. Second thing happening commonly in this system is fractures, bone fractures. Now again, our lay population, if you may have talked to your neighbor and said, oh, I fell and I broke my leg, and they'll say, oh, did you break it or did you just fracture it? Because we think a crack is a fracture and a break is all the way through the bone. That is not a true statement. A fracture is any disruption of the bony surface. So there's about 8 different types of fractures. There's spiral fractures, there's comminuted, which come through the skin. There are green stick, which looks like a green stick. We see a lot of that in kids. So any disruption of that is in there. Now, why do we see them more frequently? Well, one, they're falling. And secondly, we lose bone density. And sadly, women more than men, we lose more bone density. Because of hormone changes and so forth, women are more at risk for loss of bone density. Again, watch a commercial, Boniva for your bone density once a month to increase your bone. That's all great information, but it's, again, we're going to see those fractures occur in that. Just forms of atrophy, that's the fancy word for just wasting. Again, you're not going to have the muscular strength if you're not using it. It's not just the contractures, but just the idea that they don't have the strength and the mobility that we might have seen. So those are the things that you'll see there. All right, I'll stay on this side. Our urinary or genitourinary system is our kidneys, our ureters, our bladder, and our urethra. So we have 2 kidneys. The ureters come down from the kidneys to the bladder comes out the urethra where you urinate. So in this system, we have a high incidence of urinary tract infections. Men more than women or women more than men? Women more than men. Anatomy-wise, it creates an issue. You sit in a brief and it's soiled with stool. Just anatomy is such that it's very easy for bacteria to track up through the urethra and give these women urinary tract infections, bladder infections, kidney infections. Another thing that happens in this category is incontinence. And that's where they lose the ability to hold urine. And so they urinate on themselves. Nobody wants that to happen, but it's part of the physiology of what can happen with our elderly population. Just like up here with aspiration, there's a sub-term for incontinence called stress incontinence. And stress incontinence, sadly, starts happening for women probably somewhere between 40 and 50. Not so much men, but because many times of birthing babies, pregnancies, that bladder sling just isn't as supportive. So we start getting in that 40 to 50 range and we sneeze and we piddle on ourselves. Or we cough or we dribble on ourselves. That's just because there's not the support. So they call that stress incontinence. So just be aware that there's, again, a lot of elderly women who are out and about in the community and they're using some sort of small pad for a little bit of dribble, and the medical term is stress incontinence. Also in the system, in general, I called it holding power. They can't hold it. They don't have the ability to. We could probably, if we had to work a 12-hour shift and realize, oh my gosh, I didn't even go to the bathroom while I was working, I was so busy. We don't do that. They can't do that. That's why regulatory guidelines say that they need to be offered urination, brief change, checked every 2 hours, because they're not going to be able to hold it. And when they say they have to go, they have to go. And so it makes it very difficult for these residents to go long periods of time. They just don't have it. If you think about it, it's almost the opposite of a baby. The way we get babies toilet trained is we put them on a schedule and we start doing a system. So you're ready to toilet train your child, and you get them up in the morning, and the first thing you do is go to the big boy potty. You try to go, and then you have some breakfast, you wait a little bit, and you go to the big boy potty. And then you play, and it's just about lunchtime, and let's go potty. And we have lunch, and let's go potty. You're doing exactly the opposite you're doing exactly what happens with the elderly. You're trying to get them on a pattern, and then what ends up happening, you stretch them out, and you stretch them out, and you stretch them out. All of a sudden, one morning they wake up and go, oh, you stayed dry all night, But they can't do that anymore. They can't have that process. So we have to be aware of that, because if we don't help them through this, not just the integrity of it, but there's going to be effects on the integumentary system, which is the skin. Okay. So my integumentary system is all of the skin associated with that. So easy to know the first one. Skin breakdown, also known as bed sores, decubitus ulcers. We talked about that in chapter 4. It starts very benign as kind of a reddened area that has a pressure on it, and in 15 or 20 minutes after you take the pressure off, the red's still there. Then it can actually form a blister. Once that blister pops, you've got an open port for infection, and it can go down from there. So in the integumentary system, we really have to be on high alert for inspecting the skin and make sure they don't have skin breakdown. Also in the integumentary skin system, the skin is thin and dry, so it shears easily. It doesn't take a whole lot to hold on to a resident. You're trying to help them, and suddenly your fingers slide and the skin slides, and you think, oh, I hate that I did that. That's just some of the physiology. I think I probably mentioned in one of the previous lectures, we don't shower residents 7 days a week. I mean, all of us in this room probably, most of us in this room probably at least shower once a day or bathe once a day. If we did that to the elderly, the amount of natural oils left on their skin would make this even worse. So the skin is very thin and dry and shears easily. So just be aware of that. All right, the next system we'll go to is the digestive, also known as the gastrointestinal or GI. Now it's my mouth, down my esophagus, to my stomach, through all of my small and large intestines, and then out the rectum. So all of that is part of my gastrointestinal system. So one of the things that I have in this area of concern is constipation. There's multiple reasons that our elderly patients are constipated, but the big ones are we're not giving them enough fluid, because if we give them fluid, they wet, and if they wet, I have to change a brief, and that takes time. They're not as mobile as they used to be, so mobility affects stooling, and most of them are on a medication that will cause constipation, some sort of pain medicine or derivative that will make them constipated. So we have to be aware of that. We have to report to our charge nurse if they have not had a bowel movement at least once every 3 days. You can't let them go longer than that, because if I don't relieve constipation, then I'll end up with a bowel obstruction. So I end up with this stool that's in there, it's not moving, and we haven't addressed it. We haven't addressed it either from the upper with like a Miralax or diet. We haven't addressed it from the lower with maybe a glycerin suppository or enema. And now we've let it go too long, and a section of the intestinal tract is now blocked. Again, there can be blockages in different parts of the intestinal tract. Now, if you can imagine putting this little lady or gentleman in the hospital at 90 years of age with a bowel obstruction, they don't want us to do surgery. I mean, that's the last thing you want to do, is put somebody through surgery with this at that age. So they might put a nasogastric tube down in their stomach, Again, we talked briefly about that in chapter 8. And they might try to kind of flush this and get things moving. You know, they're doing their best. But the problem is if they ultimately need surgery, if you can imagine the surgery being going into the gastrointestinal tract, removing that obstruction and probably that section of the colon that's affected, then I've got to take these ends of the intestinal tract and I got to sew them together and I got to hope everything moves back through that system. It just doesn't go well for them. Doesn't go well at all for them. And so you just don't want them to get to this point. And you can imagine if it really gets bad and they end up with so much of this affected that I can't reasonably get those ends together, they're going to end up with a colostomy, you know, potentially to survive. And in chapter 8, the colostomy was the bag that's on the abdomen where they actually stool from their abdomen. So again, watch the constipation issues, watch for bowel obstruction, be aware. And then the last one is in this system, we just need to be aware that the digestion is slower. So for us, it may not be any big deal to have a late dinner and lay down in bed and not feel the consequences of it. But an elderly patient should not be laid down right after a feeding. It's a slower process for everything to digest. I can't run the risk of reflux or regurgitation. If I get some reflux or regurgitation, I'm likely to aspirate stomach contents, and then it's just downhill from there. So just know that it's a slower process. They might even do smaller frequent meals, but don't lay them down. That's one of the big ones. All right, the last one is the endocrine system. The endocrine system is glands. So if it's a gland, it's in the endocrine system. So pituitary gland, thyroid gland, adrenal gland. Most people don't realize that, what I've tried to draw right here, pancreas is a gland. Most of you say, yeah, I've got a pancreas in my stomach organ, but it's a gland. And it falls into the endocrine system because glands secrete hormones and the pancreas secretes insulin. So that's why it falls in that. So now that I've said that, you would know that the number one condition associated with the endocrine system is being diabetic. And so there are two forms of diabetes. We have a type 1, or many people term as juvenile diabetes, in which the pancreas just doesn't function. There's no chance that it's going to secrete insulin. They're going to end up getting insulin injections. They're going to end up getting an insulin pump. Something's going to happen with that, and that is a lifelong event. If you have type 2 diabetes, that is considered adult onset. That is usually now where this is just not functioning adequately. So the first easy thing is they start talking to these patients, let's just adjust your diet a little bit because you're just not able to handle the sugars. You don't have the insulin production. If that doesn't work, they try now to put them on an oral agent. Probably one of the newer medicines that's probably pretty phenomenal is metformin. I don't know if any of you have heard metformin. And it came out as a medication, oral medication for diabetics. It's worked phenomenally. Now, it's one of the number one drugs for infertility. Isn't that crazy? I'm a believer of metformin because I now have a daughter and a daughter-in-law with infertility that both took metformin and both got pregnant. So I'd be fascinated to learn more about the physiology about it, but it really was designed for this. If that doesn't work, they also have to go on insulin. And so there is a chance, and you can imagine, again, being somebody who's 80, how difficult it would be to have to consider some form of insulin on a daily or continual basis. Now, there are people, I know I'm too far down here, sorry. I should have put it up higher. There are people that have states of hypoglycemia, hypo meaning low, glycemia meaning sugar, who are not classified diabetics, but they have an acute sensitivity to drops in blood sugar. Some of you may have that. You may see, looking at the clock going, dang, if she doesn't break for lunch by 12 o'clock, I'm going to get shaky, and I'm going to get that headache that I get when I'm hungry. That's basically you having a period of hypoglycemia that your body's a little more sensitive to. There's nothing wrong with that. That's not a predisposing situation to being a diabetic. Just be aware of it, because it really does mean that your body's responding to those drops in sugars. Or we also see the reverse of the sugar highs and, getting some extra adrenaline or energy associated with it. So again, patients may be classified as hypoglycemic. Now, when you are dealing with your long-term care residents who are diabetic, the emergency that is life-threatening, believe it or not, is the hypo, not the hyper. I think somebody, again, that hasn't been in medicine or hadn't been exposed to it says, well, if their blood sugar is 800, they're going to die. Normal's 80 to 120. Well, they're going to die if I leave it at 800, but they could go several days with that. But if their blood sugar is supposed to be 80 to 120 and it drops to 20, they can have permanent brain effect in hours. So if you are ever unsure of a diabetic's response, if they're acting like their sugar's too low, or are they acting like their sugar's too high, you always want to err on the side of giving sugar and being wrong and making the 800 become a 900 than not have the 20 become a 120. It is that critical. In pre-hospital settings, quite a few years ago, they would put together what they called a coma cocktail. So if they found somebody unresponsive in the field setting, this was before we were dealing with so much of the opiates, part of that cocktail, that coma cocktail, was to hit them with D50, glucose. Because maybe if it's 20, I'm going to wake them up pretty quick. And again, if I'm wrong, I haven't made any mistakes. And you say, well, why wouldn't I know the difference? Well, because about half of the symptoms of hypoglycemia are also symptoms of hyperglycemia. So in your ring binder, I put a page in there in this chapter where I listed signs and symptoms, and then beside it, I put PO, PER, or both. So you see if it says both, that means they can exhibit that whether their sugar is low or their sugar is high. So again, I want to err on the side that I'm going to assume this is low. If I see this, I'm going to give them sugar, and being wrong won't kill them, because being wrong the other direction could. Or at least give them permanent brain effect. The brain needs sugar. Again, anybody that's had a baby or had a younger brother and sister brought home from the hospital, blood sugars are watched really closely in those first 24, 48 hours. Same thing, the babies can't tolerate periods of hypoglycemia because of their brain. All right, so in this chapter, what we've done is we've taken the body systems, explained what organs are in the systems, what kind of things I can see. As you flip through the rest of chapter 12, you'll see that the sections are really things we've hit on in another format. So for example, there on page 111, it talks about dementia. We've briefly discussed it here, and you've had that video. When you go to page 112, it talks about COPD. Again, we talked about it a few times previously, and it just gives you a little more information. You go to page 114, we just reviewed a little bit about the diabetic. 114 gives you a little bit more about the diabetic condition. 115 gives you a little bit more about the cardiovascular circulatory system. 117 gives you a little bit more about the nervous system or strokes associated. So it basically just takes each of these systems and expands upon it a little bit. So by the time you read through that and do your homework, I think it'll make sense. I love to teach, and I would love to give you a lot more physiology, but I also don't want to give you more than you really need, and you got a lot to put in your brain in 15 days to get ready for the test. But pretty fascinating, our body and how it's designed. But these are things that you'll potentially see, patients you'll care for, and kind of what's going on with that. So, any questions on chapter 12?